Hello, I'm Christina Murphy. I am a psychologist at the Children's Hospital of Philadelphia. I am thrilled to be presenting to you today on some research that I've done related to pediatric anxiety, depression, and headache-related disability. Before I go any further, I just want to thank my collaborators in this research. Dr. Christina Spurka, who's the medical director of our program, Dr. Carlin Patterson-Gentili, who's one of our attending neurologists, Dr. Ali Ladek, who's our physical therapist in our headache program, Dr. Blanca Marquez de Prado, who's one of our researchers, and Dr. Hershey, who is a neurologist the at Cincinnati Children's Hospital. So just to give you a little bit of background on headache for children and adolescents. So headache is the most common and disabling chronic pain presentation, and migraine is the most common disabling primary headache disorder. Prevalence of headache increases through childhood and adolescence, and as you can see, more so for females than males. And about 2% of adolescents have chronic migraine. Headache is associated with functional impairments, so children and adolescents with headaches are having difficulty attending school, socializing with their friends, missing out on time with their families, their responsibilities, their sports. They are more than 2.5 times likely to be missing school than their peers without headaches, and their quality of life is impaired, and they rate their quality of life similarly to that of children with rheumatoid arthritis or even cancer. Headache is also associated with psychological comorbidities such as anxiety and depression, and that puts kids at even higher risk for functional impairment and healthcare utilization. So how are headaches related to behavioral health concerns such as anxiety and depression? Well, one of the ways is that when our body detects any kind of stressor, it kicks into that fight or flight response, and both pain and anxiety are alarm systems in our bodies. They are designed to go off when something dangerous is happening, something physically dangerous. But unfortunately, this system developed when we developed as humans and hasn't evolved to keep up with the changes in our society. So this system, what I usually tell my patients is this system cannot tell the difference between a math test or a murderer. So it's going off when it thinks that there's something dangerous happening, and it's really our only way to manage stress, and that can include physical or emotional stress. So headaches can trigger the fight or flight response, but then stressors can also trigger the fight or other stressors can trigger the fight or flight response, which can then make it more likely that a headache is going to occur. So it can kind of happen from either end and become quite a vicious cycle. So changes in muscle tension that result from the fight or flight response can cause lingering pain, like tension headaches or jaw pain. And so even though your body isn't in actual danger, the fight or flight response can trigger pain, and then pain can also trigger the fight or flight response, creating kind of an endless loop of pain and stress. So just to give you some data on how uh, common anxiety is for children and adolescents. This data reflects prevalence rates for adolescents in particular, and you can see that anxiety disorders affect almost 32% of adolescents between 13 and 18 years old. Um, and these teenagers with untreated anxiety are at higher risk for poor performance in school, missing out on social experiences, and engaging in substance abuse. Now, I will say that prevalence rates for anxiety are lower for children under 12. So when we look at children from 3 to 17 years old, we include that younger cohort. Prevalence rates of anxiety are about 9.4%. Um, and then so again, for adolescents, about 1 in 5 teenagers are experiencing depression between 12 and 17 years old. And that is a much higher number than it would be if we considered that broad age range of 3 to 17 years. So prevalence rates of depression when we include that younger cohort are about 4.4%. Um, And we know that for the headache, for anxiety, for depression, um, psychological interventions are effective. They're feasible, they're accepted, and they are effective. So we can think about things like cognitive behavioral therapy. So this is based on the framework that how we think influences how we feel, what our body is doing, and what our actions are in any situation. So for example, if our thoughts are, I'm broken, I'll never get better, then we are more likely to feel anxious, stressed, sad, angry, and we're more likely to have physical symptoms associated with those emotions, such as, that fight or flight response can kick on. So we might have our muscles might be tense, our heart might be racing, might be sweaty, might have a headache or a belly pain, and then we're more likely to miss out on activities. And when we're missing out on things, then that reinforces that thought process of I'm broken, I'll never get better. So it all sort of reinforces each other. And the good news is that because all these things are connected, cognitive behavioral therapy says that if we can become more aware of these different areas, then we can target them to make changes. And then that allows for the opportunity for all the other areas to change, like a domino effect. So in the current study, we explored the relationship between anxiety, depression, headache-related disability, and also examined the role of psychological intervention on headache-related disability. So we hypothesized that headache-related disability will be higher for those with anxiety and or depression, but lower for those with reported involvement with a behavioral health provider. So this is a retrospective cross-sectional design. We examined intake questionnaires that were completed at a neurology clinic visit that included these were very comprehensive intake questionnaires, but we looked at demographics, behavioral health data, and the PEDMIDIS, which is a validated measure of disability for patients with headaches. looked at data from June 2017 to December 2023, and specifically for children ages 6 to 17 years of age. So over 12,000 questionnaires were collected in that time frame. We had about a little over 9,000 participants with complete data, and the data set was a majority female, median age of 13 and a half, and fairly diverse racial and ethnic representation. So about 67% of patients identified as white, 14% identified as black, and a little over 3% identified as Asian. And then we had just under 1% identified as American Indian or Alaskan Native, and about 14% had an unknown. We didn't know their race, and 8.5% reported that they were Hispanic. Like I mentioned earlier, we used the PEDMIDAS to assess for headache-related disability, and this examines the past 3 months, how many days of school the patient has missed, how many times they've missed chores or activities due to headache, and higher scores indicate more disability. To assess for anxiety and depression, patients were prompted to check all that apply for behavioral health diagnoses listed. And so we created, so options for behavioral health diagnoses included none, ADHD, anxiety, depression, behavior problems, oppositional defiance, obsessive compulsive disorder, autism, and then included in that list, it also asked if they had ever been involved with a behavioral health care provider, such as a social worker, psychologist, or psychiatrist. So we created 4 categories. Those included no anxiety or depression, anxiety only, depression only, anxiety and depression together, since patients could check all that apply. We also assessed for headache characteristics, so frequency and severity, continuous headache versus intermittent or episodic. We also looked at triggers and associated symptoms. So we used a univariate and multiple robust linear regression model. We adjusted for demographics, headache characteristics, and ADHD because of the high prevalence. For the multiple regression analysis, our main predictor was the presence of anxiety and or depression, and our main outcome was headache-related disability as measured by the PEDMIDAS. So we performed a univariable sub-analysis to determine the impact of having a behavioral health provider, so social worker, psychologist, or psychiatrist involved in headache-related disability. And that, so that's not the first thing listed here, but I can just share about that result. And for those with anxiety or depression, and contrary to our hypothesis, having a behavioral health provider was related to a higher level of headache-related disability compared to those without a behavioral health provider. So we also found that those with anxiety only had higher levels of disability compared to not having either diagnosis of anxiety or depression. There was not a significant relationship between depression and headache-related disability, and we suspect that this was due to the depression group being a fairly small group, making it more difficult to detect in effect. Those with anxiety and depression together had um, had higher levels of disability, headache-related disability, compared to not having either diagnosis at all. So in summary, we see that anxiety and depression are associated with headache-related disability. We also see that behavioral health involvement may indicate that this is a group of patients with a really high level of need, and thus indicate, why they had higher levels of disability. So one of the things that I think this data point to is the importance of having an integrated care model for our patients with headache. Um, it is really important to address both headache and behavioral health concerns from this biopsychosocial framework. Um, so I think a lot of times patients can be a little put off by the idea that, by this notion that, oh, they don't want to feel dismissed. Of course, we don't want them to feel like the headache is all in their head or it's psychosomatic. But when we can address concerns holistically from this biopsychosocial framework, it is effective and validating for patients and their families. So letting them know that yes, genetics, you know, comorbidities, medication, they play an important role in headache care. But how we think about our pain, how our body responds to stress, the social things going on in our life, like what's going on at school, what's going on with friends, but also our sleep, our exercise, our our hydration. All of those things are really important. Just all equally important. And I think that this data really supports that the use of this framework and use of allied health professionals in headache care. So just some limitations. This was a cross-sectional design, so not able um, to demonstrate or suggest causality. This was a single center specialty clinic sample. And so just a note about reporting, the headache intake questionnaire does prompt for the patient themselves to complete it, but and it does ask who is completing the questionnaire at the top, but it doesn't ask that again. So it is impossible to tell if, perhaps the child started the questionnaire, but then the parent took it over, or the parent, indicated that the child might be completing, but the parent completed it. So it is difficult to tell who completed the questionnaire. So some of this data could be parent report. Thank you so much for having me. And if you could please take a quick survey about this presentation, that would be incredibly helpful for me. So you can go to the link listed, or you can you can center your smartphone camera on this QR code, and it will take you to the survey. Thank you so much.